Thank you. Good afternoon, ladies and gentlemen. Luis asked me to speak about the thrombectomy from small vessels, and I think it's a good time to do this. I have to admit that I'm co-inventor of the both company and of the device. If you go to the MAGIC 4, I think meanwhile MAGIC 7 studies, we have to say they prove that mechanical thrombectomy is very efficient and safe for acute stroke, but they don't really address the treatment of small arteries for a variety of reasons. One of those reasons is that several of these studies mainly enrolled patients under conscious sedation or kind of local anesthesia, and what I show you is probably not really easy to do if a patient is not really intubated and sedated. And for the majority of these trials, those devices were not yet really available. As we all know, the limitation of thrombectomy at the technical status we had, let's say 3-4 years ago, was that we had devices that were suitable for 2 millimeter, 2.5, 3 millimeter vessels, but there was nothing really suitable for small vessels. These, let's say, first generation thrombectomy devices were approved and essentially designed for vessels being in the range of 2.5 or 3 millimeters in diameter. Now we have more devices available. There is Catch Mini, which is kind of a copycat of Solitaire with a nominal diameter of 3 millimeters. It's approved for 1.5 millimeter vessel diameter. Baby Trevo is again another 3 millimeter device. Preset LT 3 millimeter and 4 millimeters are available. They are approved for 1.5 millimeter and more, for more than 1.5 millimeter vessels, but they work perfectly for even down to 1 millimeter. All these low profile thrombectomy devices are accepted by 0.17 inch ID microcatheters, so SL10 or Echelon 10 will do for these devices. Preset LT it comes in a standard size. It's 4x20 or 6x30. Those are accepted by 0.021 catheters, pretty big catheters for small vessels. The 4x20 is made for vessels with a diameter of more than 2 millimeters, and the 630 is made for vessels with more than 3 millimeters. So what happens if you have a reasonable thrombectomy result for the M1 segment, as in this case, but here the superior branch is still occluded? Go away or just do it? The LT devices for preset are different from the regular device. One of the differences is that the regular preset has these kind of markers. These are the ends of the struts. Here, those are radiopaque markers. This is different for the low-profile device. For the low-profile device, the marker is integrated into the struts of the device. They are not these little pins reaching up distally to the device. And another difference is shown here. This is the radial force curve of the regular device. This is for preset LT 4x20 and for preset LT 3x20. As you see here, the radial force is significantly lower for the LT version than for the regular version. This is very simple to understand. What is the background? To make the device accepted by a lower profile microcatheter, you have to make the struts thinner. If you thinner the struts, the radial force will be lower as well. This is again the same example. Thrombectomy has been done in the M1 segment. The M1 is patent, and the superior branch of the MCA is still occluded. Now we catheterize the superior branch, the superior truncus of the MCA, and go for thrombectomy. It's very simple, very straightforward procedure. The thrombectomy in this case was done, as in most of our cases we do today, with a aspiration catheter just in front of the origin of this small vessel. Another example, as you may see here, it's quite distal here. This branch is still occluded. It's here. Catheterization of this branch, this is here, it's hard to see, this is the mark of the microcatheter. This is the course of the thrombectomy device in this moment. You wait for another 3 to 5 minutes, do the thrombectomy, and you may expect the patency of this artery. Next example, catheterization of the occluded branch, waiting for a couple of minutes, going for thrombectomy, taking out the thrombus. There's no success. You may find out another solution. This is the beginning of the procedure. This is thrombus after 4x20, and we waited for a couple of minutes and had reocclusion. We did it again with a 4x20, and 10 minutes later, the vessel is occluding again. In the far majority of the cases, the reason why this happens is a dissecting of the artery through the thrombectomy. And if this happens, the best choice you may have is just coming back, putting a catheter in the re-occluded artery and deploying a solitaire, which may help you out. This is after 45 minutes, and the artery stayed patent, and we deployed the stent. For the majority of, in the majority of cases, you may go away with just giving aspirin IV, which we usually give anyways. If you have doubts or if you feel insecure, a bolus of integralin, eptifibatide, is enough to prevent occlusion of this stented vessel if you have to go for a stent. This was a patient. He had undergone vascular surgery for an asymptomatic ICA stenosis, and after the surgery, the ICA was occluded, and the patient had emboli in both anterior and middle cerebral artery, and was quite symptomatic. NIH stroke scale was 17 points. So we reopened the ICA with a stent and went for thrombectomy. There were stents in the pericallosal artery. We discussed, should we do it or shouldn't we do it, and seeing the angiogram, our impression was that the pericallosal artery and the callosal marginal artery were quite needed in order to give supply to the leptomeningeal collaterals. So we did peripheral thrombectomy in both vessels. This is seen here, and all of a sudden there's a minor leakage from the internal frontal artery here, as you may see here. This is the point that continues. It's a minor extravasation, which is it's usually quite benign. So in that case, we just lowered the blood pressure. The glue for gluing the artery was already prepared, but we lowered the blood pressure, and within a very short time you will see that there is a cessation of the extravasation. The patient stopped bleeding from this vessel, and the result was, I would say, not too bad. There's minor leakage. So the key question is, what is the recanalization rate we may expect, and what are the safety margins of this peripheral thrombectomy? In these very small vessels, we evaluated the preset LT data, and the cases were extracted from our institutional database, which is meanwhile a little over 2,500 cases we did since 2008. And the fellow who did this, she selected cases in a certain time interval. I will show you in a second. She analyzed the recanalization numbers of the target vessels and all kinds of complications. The procedure itself, it's pretty much standard. So we use in the anterior circulation 8 French guide and intermediate catheters. Posterior circulation, we usually use 6 French guide and intermediate catheters. Our standard catheters for thrombectomy are PX Velocity Echelon 14 or Trevo Pro for standard procedures, and we usually use meanwhile SL10 for peripheral thrombectomy. Standard wire is Synchro 14, and we deploy the thrombectomy device. This is true for both, for proximal and distal thrombectomy. We deploy the device, wait for 5 minutes, give something between 0.5 and 1 milligram of glycerol trinitrate in order to relax the arteries and prevent vasospasm, and then go for very slow device retraction with a simultaneous aspiration as far as possible. Meanwhile, we use Sophia for the Sophia aspiration catheter for a distal thrombectomy. If we fail, we either go for angioplasty or deploy a stent, as you have seen. In the series between 2013 and 2015, we had a selection of 76 patients. I mean, in this period, we treated way more. Those are the patients who had any distal thrombectomy. The quite old patient, 71 years average age. The average onset of treatment prior to treatment was 255 minutes. This is related to the fact that many of patients treated by us are coming from far distance. Stuttgart is surrounded by a huge area of rural communities, so they have quite a long time to arrive in the central hospital. And the median NIH stroke scale was 14, so medium severe strokes, I would say. These are the target vessels, 79 primary target vessels. Primary should say the majority of these distal thrombectomies were not directed towards primary target vessels. We did this in the setting of either primary or secondary thrombectomy. So you see here pericallosal artery, basilar artery, P1 or P2 segment. These are certainly not good targets for a regular 4x20 thrombectomy device. This should be done with a device which is dedicated for small vessels. TICI 2B or 3 was achieved in 87% of these primary target vessels. And if you go to the subset of data for the preset LT targets, this was M1, so in very tiny M1 segments you may contemplate to use a low-profile device in temporal MCA branches, M2, A2, pericallosal artery, callosal marginal artery, basilar artery if it's a thin vessel, or P1, P2 segments. So actually you could say there is no real limit in terms of vessel diameter. The question is not the vessel diameter, the question is does it deserve the effort? Is the vessel for the brain supply important enough to undertake the effort and the risk for the patient to go for the thrombectomy? This is certainly, I mean, it depends on the appreciation of the operator, but the numbers you see here should not say it's limited to these vessels, but these were vessels we thought the patient may have a benefit if we take out the thrombus from there. The recanalization rate is pretty high for this device. The TICI 2B3 recanalization rate is 70%, which is, I think it's a good number if you consider the fact that these are far distal, very thin, very tiny vessels. So in, let's say, 2 out of 3 cases, you may expect with 1 or 2 passages recanalization of the vessel. Vasospasm is not infrequent. You may expect that these tiny vessels are not really happy to be treated with a thrombectomy device. So vasospasm in something like 7 to 8%. Dissection is rare, and dissection is mostly related to very tortuous vessels. So I would be quite reluctant to go in very tortuous anatomy for distal thrombectomy. The one case with the extravasation I had shown to you, and thrombus to other vessels may occur if you fail for any reason to go with your aspiration catheter close enough to the device. Focal hemorrhage is frequent. The focal hemorrhage is kind of a focal subarachnoid blood accumulation. It's around 10 to 15%. Parenchymal hemorrhage is infrequent, 2%, and unrelated things like subarachnoid hemorrhage in any other territory was registered, but it's of course unrelated to the thrombectomy. So in overall, the expected recanalization rate from these low-profile devices for far distal thrombectomy is roughly 7% successful recanalization. About 6-7% vasospasm, 2% dissection, 1% perforation in this series, and 3% new emboli to previously non-occluded arteries. And the far majority of the subarachnoid hemorrhage is completely irrelevant for the clinical outcome, fortunately. It's a useful complementary device. It is the subarachnoid hemorrhage rate in the first moment was slightly irritating, and we were quite pleased to see that it has no impact on the clinical outcome of the patient. If you go to the clinical effect or clinical benefit, and if you analyze CT and MR images afterwards, you will recognize that about 2/3 of these recanalized vessels really end up in a non-infarct. So it really deserves the effort. There are, I mean, if there is no leptomeningeal collaterals at all, the dependent territory will undergo infarct anyways. But if there's a sufficient amount of collateral supply to the artery, to the territory of the artery which is occluded, you may really expect that taking out the thrombus from these distal vessels does help to prevent infarct from these areas. Thank you.
Thank you, Professor Henkes. I think these devices to the thrombectomy in the small vessel is I need is important. I think it's not very difficult to use. But for the question is the indication. You are two situations. One, the patient comes with the symptom secondary to distal embol. Okay, M3. This is depending on the clinic, and this is mandatory. It's possible to retrieve the clot with intravascular devices. But the second situation is when you remove the clot in the middle cerebral artery. Sometimes you are the migration, and you are the distal migration, and this is what do you think? You need to remove this clot, or you wait and you analyze the anatomical or collateral circulation or clinical, if it's possible, analyze the clinical. Because sometimes only with the microcatheterization of the vessel, distal vessel, or infusion of the small part of heparin or fibrinolytic is successful to cure the symptom. Do you think this is correct?
Yeah, that's a really complex topic. We had to learn a lot of things when we started to do a stroke case on this large scale. One of the lessons we had to learn is kind of an oxymoron of the neurological stroke treatment. If you go to the books, you will see that for patients having undergone intravenous thrombolysis, heparin is contraindicated. Our anesthesiologist said it's hard to understand. RTPA works way better if you give heparin. Since we learned this, we started, as soon as the patient is coming, having had intravenous thrombolysis, the first thing we do is giving heparin, 5,000 units heparin. We didn't see any increase in the hemorrhage rate, but we saw a significant increase in the rate of thrombolysis during our procedures. So giving heparin may help you not to come in a position where you have to go for distal thrombectomy. Another aspect. In the very beginning, when we had no distal aspiration catheters, we had a significant number. Significant means 15% of emboli ending up in the anterior cerebral artery while we were doing thrombectomy from the middle cerebral artery. Since we have this thrombectomy catheters, the occurrence of ACA emboli coming from the MCA is very low. It disappeared as a phenomenon. So yes, I mean, if you are not lucky and you end up with a thrombus coming from the MCA going to the AC, it's certainly better to take it out than to wait for the patient. Patient will have another stroke territory, which is in the far majority not good. So the next point is we do all procedures under general anesthesia. We have no chance to observe the patient if this is of any relevance for him or not. Every now and then we try to do it under local anesthesia. And to be honest, I don't understand what's the difference between the Dutch patients and the German patients, but I can tell the German patients don't tolerate this thing under general anesthesia. They start doing all things you don't want to see. They start yelling, they start vomiting, they start doing all crazy stuff as long as they are not under general anesthesia. So in our practice, everything is done under general anesthesia, and we can't evaluate if this occluded vessel is of any relevance for the patient or not.
But sometimes it's possible to move the microembol to move
Sure.
the catheter, no?
Sure.
I think this is a problem.
If it goes further distal, and if you think the affected or the dependent brain area is maybe not so significant, it's probably a good idea just to leave it there. I mean, that's the thing per se is safe, but going into the distal callosal marginal artery, just opening an artery which may or may not supply leptomeningeal collaterals, can be quite scary.
Yes, when you stop, when do you stop you are the embol migration, and why? I think it's better to stop, or I think it's better to remove this. But this is the anatomical analysis
Sure.
of the collateral circulation. Maybe you are the solution. But I think it's very important these devices. And finally, another question. When you treated the basilar stroke, vertebrovascular thrombus, sometimes you are, many times you are the migration of the embol and the small vessel of the cerebral arteries and cortical cerebral arteries, and this is it is a high problem to the patient, because si the patient is treated before with intravenous fibrinolysis, it's impossible to decompression, surgery decompressive. And I think is in vertebrovascular territories, for me, I recommend don't use the intravenous fibrinolysis, because you have the risk of migration of the thrombus and you have possibility. What do you think of this?
Yeah. Meanwhile, we did a couple of thrombectomies, both from superior cerebral artery and from pica, and this is easily possible. I'm not aware of a case we did from the ICA, but superior cerebellar and pica is technically quite straightforward. It's no big deal to go to catheterize these vessels and with these low-profile devices and do thrombectomy there.
I just wanted to ask, why do you give the nitrate? Do you think it's...
The nitrate is given in order to guarantee instantaneous vessel relaxation. If you use nimodipine, the action to become effective may take 15-20 minutes to be effective with nimodipine. If you give glycerol trinitrate, you have literally instantaneous vessel relaxation. So you won't, even with these relatively brutal things, you won't induce any vasospasm.